The exams I wrote for, you remember what I'm speaking about.
Exactly.
Go ahead, Roy.
Mr. Chairman, ladies and gentlemen, it's my pleasure to give you an overview about the European trauma guidelines, the update. It's clear that there are some conflicts of interest. If you are in a field, you have to give lectures on that, and you have also sometimes to consult the different companies. So the trauma guidelines are now updated a second time. We started with the trauma guidelines in 2007, and our goal is to update them every 3 years. And so far we are successful, and the next update is planned to be published in 2016. So basically it was a group of colleagues from all of the European countries stating, okay, we have to give some educational material to our physicians, but we believe that we need the professional societies on board to write these guidelines and to enforce these guidelines. And so we have six European societies who are supporting us and delegating always at least one member to be part of the guideline writing process. So this is a core group chaired by Donat Spahn and by myself, and we have from all the different countries different colleagues, anesthesiologists, intensivists, hematologists, difficult word, and internists and so on. So it's a good group. At present, the guideline consists of 6 parts, and I will cover shortly all the different parts with exception of tissue oxygenation and fluids and hypothermia, because this was already covered by Gernot Marx in part and will be covered by Jacques Duranton, so I will keep this out. So, as already mentioned by the colleague in his comment before, it's very important that we really fast try to get the trauma patient from the accident site to the OR in order to stop the bleeding. And we know that this time period from the moment the physician is arriving at the scene until he is arriving at the emergency department is a time of 72 minutes in Germany, all over the trauma patients. And this is still much too long, even if we have to keep in mind that some of the patients had to be rescued out of their crashed mobile, and that's sometimes very difficult. So we believe that we have to keep in mind that there should be a minimal elapsed time period between traumatic injury and admission to the OR. Second very important point is diagnosis and monitoring of bleeding. It is clear that we should have in mind that many of these patients develop a coagulopathy, and therefore we need to establish early and repeated and combined measurement of prothrombin time, activated partial thromboplastin time, fibrinogen, and platelets. We know this. But at least in our hospital, between the start of the blood drawing from the patients to get these numbers, until we get the numbers, we have a time period of about 45 to 60 minutes. And I'm sure this will be the same in your hospital. But nowadays we can use also thromboelastometry and graphy, and this will give us very fast an impression how the coagulation is working if we have, for example, such a prolonged time before a first coagul is appearing. It's stating, okay, you have a problem. If we have this hyperfibrinolysis picture, then it's very clear what we have to do. I believe that this is really a helpful part in our coagulation management, and therefore the new guideline is now saying it's a grade 2B recommendation. I will not speak about tissue oxygenation. What about rapid control of the bleeding? As mentioned before from the colleague with his comment, and also in our guideline, we believe that it's very important that we have early bleeding control. Because so long as it's bleeding, you will have a problem with coagulation. You will have the problem, what is the best fluid to give the patient in this phase. And we have the discussion later on vasoactive drugs. When should I use it? How much should I use it? And therefore we believe bleeding control is the most important part from the surgical point of view. And this will also have an influence what we are doing as anesthesiologists and intensivists. So I believe that we should use for the abdominal bleeding, we should use packing, direct surgical bleeding control, and sometimes the use of local hemostatic procedures. And in some of these patients where the exsanguination is really inside for this patient, then we should use Arctic cross clamping in these cases. If we have the pelvic fractures, we should have in mind that we have very often a massive bleeding in this group of patients, and we should try to get a pelvic closure, and we can use these external fixators, bed sheet, pelvic binders, or pelvic C-clamps. Everything is working better as to do nothing, and also already for the transport of the patient, we can use some of these devices. So what about damage control surgery? Should we try to get the surgeon manipulated in that way? I would like to say that he is doing damage control surgery. And in which group of patients? I believe always if a severely injured patient is showing signs of hemorrhagic shocks, signs of ongoing bleeding, and signs of coagulopathy, that's always an indication for damage control surgery. So that means that the surgeon is doing the shortest surgical procedure which is possible, that he should use packing, that he should use external fixators in order to keep the surgical time as short as possible. Then we have some other factors, and these are sometimes debatable, but nevertheless, at present the recommendation is, and this is a strong recommendation, even if the evidence is not so good, it's a 1C recommendation, that we should use damage control surgery always in patients where we see severe coagulopathy, hypothermia, acidosis, or inaccessible major anatomic injury, where we need a long time for the final procedure, final surgical procedure. And we believe that then the primary definitive surgical management should be done in a time phase where the patient is hemodynamically stable, and this is usually 1 or 2 days later. What can we do as intensivists and anesthesiologists in order to manage the bleeding and the coagulation? What we have to realize is that already 25% of all the patients admitted into our emergency department are showing signs of coagulopathy. So they were not treated so far, but due to their trauma, due to that what has been done before, mostly fluid to the patient, 25 of these patients are showing signs of coagulopathy. And this group of patients showing a coagulopathy has a 3- to 4-fold higher mortality. And therefore, we have to keep in mind that coagulopathy is one of the most, the biggest problem we have in this group of patients. And the CREST-2 study demonstrated very nicely in a large group of patients. 20,000 people were randomized, 10,000 people to the tranexamic acid group and 10,000 patients to the placebo group. And they could demonstrate very nicely that any cause of death was reduced in the group of patients receiving tranexamic acid. And basically, there was nothing else defined how to treat the patient. It was only that it was defined tranexamic acid or not. And this study was done also in many of third world countries. And even then, you could demonstrate this benefit. The bleeding was slightly reduced, but more important, the mortality rate was slightly induced. And that was the reason that we now recommend that tranexamic acid should be used in all the trauma patients who are bleeding and are showing signs of coagulopathy or showing signs of significant hemorrhage. And in this group of patients, you should start with tranexamic acid as soon as possible, if possible within the first hour, and the latest 3 hours after injury. We have seen that these patients treated later than 3 hours after injury, that they will not benefit from this approach. And there are some discussion whether we should already start before the patient is arriving in the hospital with the tranexamic acid. So this is debatable, but nevertheless we gave that recommendation with grade 2C. Then in the last year, since 2008, we had a lot of publications stating we should use a high ratio of fresh frozen plasma to red blood cells, and it was always recommended to have in these studies, in these observational retrospective studies, that we should use a 1-to-1 ratio. And here is one study doing an analysis in all the patients receiving between 4 and 10 red packed blood cells, and in this group of patients they had 3 different ratios: a lower ratio than 1-to-1, a ratio of 1-to-1, and a higher ratio, even a higher ratio of 1-to-1. And in this study it could clearly be demonstrated that this group receiving fresh frozen plasma to RBC ratio of higher than 1-to-1, that the hospital mortality was reduced. But again, this was a retrospective studies. And nowadays we have some studies, they are not supporting this topic. For example, a retrospective analysis in 1,700 trauma patients receiving less than 10 RBC in the first 24 hours, and they could find that if they were using a lower ratio between, of FFP to RBC of less than 1-to-2, that then the ICU-free days were higher than in the group receiving an equal or higher ratio of 1-to-2, and therefore it is still debatable. And also the ventilator-free days were in favor of a lower ratio. And furthermore, there is now very recently a Canadian study published, and this study published in 2013, they clearly even showed a reduction in mortality if there was a lower ratio of 1-to-1 used in the trauma patient. So we have to wait for further prospective randomized studies on this topic, but we have to keep in mind that all the studies are shown if we are using a lot of FFPs in our trauma patient, and if we are using, for example, more than 6 units, then the independent hazard ratio for development of multiple organ failure or RDS is significantly increased. And therefore, I believe we have to be cautious with our recommendation. And that was a reason that we also stated, okay, we recommend the initial administration of plasma, but also we are saying you can also use fibrinogen in patients with massive bleeding. And if you are using plasma, then we don't believe that we should use a higher ratio of fresh frozen plasma to RBC than 1-to-2. So we believe that could be a good ratio, but we are not sure about that. So it's a weak recommendation in our guideline. And we believe that we should, in all cases where we have not a substantial bleeding, that we should avoid plasma transfusion. So what about fibrinogen? Yes, fibrinogen is absolutely necessary for coagulation, but unfortunately we do not know what is the right level of fibrinogen. So in contrast to our former guidelines, we now recommend a higher level of fibrinogen. We have to state that the evidence of this is low, but we feel that it's necessary to make also the same a strong recommendation for this, and so we believe that this is a good value, but we are still missing the good studies showing that this is the right way to do it. What about platelets? When I started to do anesthesiology in intensive care, I was always told try to keep the platelet level above 50,000. Nowadays, we are stating, okay, if you have a patient with multiple trauma who is still bleeding, or if you have traumatic brain injury, then please increase the platelet count to more than 100,000. And therefore, we again gave now a recommendation for this. The evidence, as you might see, is still weak. It's a C recommendation, but the letter is also a weak recommendation because the literature is not very good on this. What about the prothrombin complex concentrated PCC? Should we use it? It's clear if you have warfarin in the patient, then you should use it. That was always clear. But now we have some studies showing that you might use a goal-directed coagulation strategy if you are using thromboelastometry guided administration of fibrinogen and PCC, and we have now some studies showing that this might be of benefit for the patients, and Herbert Schöschel published one retrospective analysis where he analyzed all the patients receiving more than 5 RBC concentrates within the first 24 hours. He identified 131 patients, and in 190 patients he only used fibrinogen and prothrombin complex concentrate. In 12 patients he also used, in addition, some FFP. And he could demonstrate when analyzing his data and comparing this with 2 different trauma injury severity scores, with a TRIS and with a risk score, that the observed mortality was lower than the predicted mortality with the different tools. And this was true for all the patients, and it was even nearly half the amount of patients dying when they used these scores only for patients without brain injury. So that is the reason that we are now saying, okay, if a concentrate-based goal-directed strategy is applied, then we suggest that PCC be administered in the bleeding patient with thromboelastometric evidence of delayed coagulation initiation. What about the recombinant factor 7A? At a certain time point 8 years ago, we believed that is a magic bullet, and that could be at least a magic bullet, and we started to study that. The first study showed that this of benefit. We could reduce the ARDS incidence in the patient, and then the second study, the control study, which aimed to include more than 1,500 patients, finally was stopped due to feasibility. After randomization, more than 500 patients in the blunt trauma group, nearly 500 patients were randomized, and unfortunately the mortality rate was not different in both groups. The mortality rate was only 11%, and in my eyes the major problem of this study was that they included the wrong patient. They were not severely enough injured, and therefore we didn't find any effect of this drug. After this study has been published, Levi analyzed all the 35 randomized clinical trials where recombinant factor 7A was used and compared this to the placebo group, and he could clearly demonstrate that the number of arterial thromboembolic events was increased in the group receiving recombinant factor 7A in comparison to the patients receiving placebo, and he stated that we always should make a risk-benefit consideration when we are evaluating to administer this drug to our patient. I believe that this group of trauma patients is still a group where we can use it, but I believe the recommendation could be only a weak recommendation. The evidence is not good enough to make a B out of it. It's still a C, and therefore I think we can consider it, but all the other possible strategies we can apply to these patients have to be applied before we are doing and treating the patient with that. In our new guideline, we have a focus also on implementation of the guidelines. We learned a lot from the implementation in the Surviving Sepsis campaign. It was a very good strategy, and we now believe that we need treatment algorithm, that we need checklists, and that we need also quality management. So we believe that each institution should have an algorithm for the bleeding trauma patient, that we should try to observe whether this algorithm is followed in the own institution, and there has to be an assessment of the adherence. We have seen in the Survival Sepsis campaign that the adherence is very often bad, and therefore we believe that we have to work on this. For that, we started the Stop the Bleeding campaign in order to create the awareness and to set up some possibilities and some ideas how to create the adherence and necessary adherence in this field. So we believe that the Stop the Bleeding campaign with the acronym STOP, search for the patient at risk of bleeding, treat the bleeding, observe the response to the intervention, and prevent secondary bleeding might be a way to create the awareness and